Hello viewers, I am back again with the part 3 of temporary anchorage devices in orthodontics. Those of you who have missed part 1 and part 2, please do look up the link and get yourselves acquainted with part 1 and part 2 for a smooth understanding of the temporary anchorage devices in orthodontics. So the part 3 we would be dealing with the sites of microimplant placement in the mandible, as also I shall be giving you some information about the extra-alveolar screws, namely the infrazygomatic crest screws and the mandibular buccal shelf screws. So what are the microimplant sites in the mandible? Retromolar area, between the first and the second molar buccally, between the first molar and the second premolar buccally, between the canine and the first premolar buccally, mandibular symphysis facially, edentulous areas, mandibular lingual tori, etc. So we shall come to the mandible, the retromolar area. Here lever arm mechanics with a bracket head type microimplant can also be used. But here the surgical considerations are adequate thickness and high quality of cortical bone needs to be present. The retromolar mucosa is as thick as that of palate. The microimplant must be at least 4 mm into the bone. Microimplants placed on the distobuccal aspect of the mandibular second molar tend to be covered by soft tissue. And there is also small interocclusal clearance which causes an occlusal contact between the microimplants and the maxillary teeth. So we need to take an account of all these surgical considerations. So in the mandible, in the retromolar area, we can use a diameter of about 1.4 to 1.6 mm and the length can be about 5 to 10 mm. What's the purpose of putting it here? To upright the tilted mandibular molars, retract the mandibular teeth or the whole mandibular dentition. You can just look at the diagrams and you would be able to appreciate what I am saying. So you can see here a lingually tilted mandibular second molar being uprighted by placing a microimplant buccal to second molar, because in some patients there is sufficient alveolar bone which is about 5.3 mm for placement, and the microimplant can be positioned perpendicularly when placed apically. Well, between first and second molars buccally, the diameter is about 1.3 to 1.6 mm and a length of about 5 to 7 mm can be used. I think so you can appreciate the figure where the microimplant has been placed between the first and the second molars buccally, and then you also see the retraction coin spring being used. The purpose is to retract the mandibular anterior teeth. The microimplant can also be placed between the first and the second molars buccally. Why so? For effective intrusion and distal movement of the mandibular molars and correction of scissors bite, like the buccal cross bite and the Brody bite. It can also be placed between the first molar and the second premolar buccally. A diameter of about 1.3 to 1.6 mm can be used and a length of about 5 to 7 mm. The purpose is to retract the mandibular anterior teeth and for intrusion of mandibular posterior teeth. What are the surgical considerations? There is a narrow attached gingiva here, but there is a good quality cortical bone and the volume of the buccal alveolar bone is thin, so microimplant should be placed slightly lower than normal and in a perpendicular direction. Between the first molar and the second premolar buccally, if you do this, then you can use a crimpable hook, you can use an open coil spring, compress it, and then the crimpable hook can be attached to the microimplant, which would produce absolute anchorage and prevent the force being transmitted to the anterior region, such that all the force is transmitted to the first molar and the first and the second molars move distally. So that's the advantage of using this microimplant for absolute anchorage in this particular region. Yes, it can also be used between the canine and the premolar buccally. A diameter of about 1.3 to 1.6 millimeters can be used, and a length of about 5 to 7 millimeters. So with this particular type of the wire and the microimplant that you see there and the bracket which has been positioned on the first mandibular molar, you can see you can also protract the mandibular molar. So it is not necessarily distalization, but also protraction of mandibular molars can be done. But then the surgical consideration here is that there is a narrow attached gingiva. The distance between the canine and the first premolar roots is 2.2 millimeter. The volume of the buccal alveolar bone is thin. This area can be used as bicortical anchorage. So what do we mean by a bicortical anchorage? It means that the microimplant passes through both the buccal and the lingual cortical plates. Yes, a microimplant can also be used between the canine and the lateral incisor labially. Purpose: useful for moving the molars mesially. Microimplant can also be placed in the mandibular symphysis facially. A diameter of about 1.3 to 1.4 millimeter can be used, and a length of about 5 to 6 millimeter. Purpose: to intrude the mandibular incisors, as we do the same thing in the maxillary incisors when we place it in between the maxillary incisors. Same scenario for the mandibular incisors too. What are the surgical considerations here? There is a narrow band of attached gingiva. The bone is of good quality, no doubt. The distance between the roots of the mandibular anterior teeth is small. We all know that. Hence, here you have to place the microimplants diagonally and slightly in a lower position relative to the roots of these teeth so that you do not injure them. Of course, if you have certain edentulous areas, these are the best areas for you to place the microimplant without any impediment from the tooth roots. So a diameter of about 1.3 to 1.6 millimeter can be used, and a length of about 7 to 8 millimeters can be used. So this is the best area for controlling teeth adjacent to an edentulous space to achieve movements such as molar uprighting. What are the surgical considerations? Good quality cortical bone, and there is no risk of root injury. 2 MIs can also be placed, as you can see in the figure. What you see there is 2 microimplants are placed a little apart but side by side, with their upper structure connected with a light cure resin to which brackets can be attached, which can also be used as artificial teeth. So whereby you can bring about distalization or mesialization as the case may be. We can also place it in the mandibular tori region. Now what is the mandibular tori? We do encounter certain patients who have a thick exostosis of bone on the lingual surface. So if you really want to bring about intrusion of the mandibular first and the second molar, we can place an implant in the mandibular tori on the lingual surface, and you can place a buccal implant between the mandibular first and the second molar on the buccal surface. You can have a little piece of wire which can be bonded to the first and the second molars, and then you can use an E-chain or whatever, or an elastic, and you can bring about effective intrusion. If there is any bone adjacent to the residual roots, that will be extracted later, best place. Why? Because until such time we have residual roots, we have alveolar bone. The moment we remove the residual roots, the bone gets a little bit resorbed. So make good use of the bone which is present adjacent to the residual roots, achieve what you want to achieve, and then remove the residual roots. These are little tips that you can practice in your clinical practice. So what are the surgical considerations? Microimplants are placed 2 to 3 millimeters apical to the attached gingiva, but diagonally. Why so? Due to a narrow band of attached gingiva. The quality of bone is excellent and is about 3 millimeter. The possibility of root damage during microimplant placement between mandibular first molar and second molars is much less than that in maxillary arch, since the distance between them is 4.5 millimeter. But then you also have the alveolar canal with it, the inferior alveolar nerve. So all these things needs to be taken into consideration. So the anatomical considerations also are very important when you place it in this particular region. So now this is a little small little example where a patient has a skeletal class 3 malocclusion. He has a little bit of a retrognathic maxilla and prognathic mandible. The patient does not prefer orthognathic surgery. He's a skeletal class 3. So what I thought I would do would be, why not place a microimplant between the mandibular first molar and the mandibular second premolar, and after having extracted the mandibular first premolars, I would attempt to retract the whole mandibular arch into the extraction space. Could I do this? Is this possible? Yes, of course, it is possible, and that's what we did. So after having placed the microimplant between the mandibular first molar and the second premolar, and by using a long crimpable hook such that the force is closer towards the center of resistance of the mandible, and we used a retraction coil spring, and we tend to retract the mandibular anterior segment distally. And this is how the patient was at the end of the active orthodontic treatment with microimplants. The left side you see the pre, and on the right side you see the post, and then you can see the patient has a beautiful consonant smile arc. So all these what you call the border cases where the need to go for an orthognathic surgery can be successfully treated with the use of microimplants. This is just to show an example of what microimplants can do. So now we have dealt with the sites of placement in the mandible. Now we shall go on to extra-alveolar screws. Now in my part 2 and in my part 3, I have dealt with those sites of placement of microimplants between the teeth. So when the teeth move, the tooth roots can come into contact with that of the implant. Now do we have something which can bypass this? Is there something that we can place extra-alveolar or extra-radicular such that when we distalize the teeth, there would be no interference from the microimplants? Can we do that? Yes, it is possible. With the advent of the infrazygomatic crest screws and the mandibular buccal shelf screws, we are able to achieve this too. So now we're going to talk about a little about the infrazygomatic crest screws. For that, we need to understand the anatomy of the infrazygomatic crest. So what is this infrazygomatic crest? It is a buccal process on the maxilla connecting to the zygoma emanating from the buccal plate of the alveolar process lateral to the roots of the first and second maxillary molars. We have something known as the IZC6 versus the IZC7. So what is this infrazygomatic crest? If I were to explain it more explicitly, it is a ridge of bone which extends 2 cm or more superiorly to the zygomatic maxillary suture, and the inferior portion can be subdivided into the IZC6 and IZC7 areas. So, a practical position for an IZC bone screw is anterior to the anatomic ridge and buccal to the mesiobuccal root of the maxillary first molar. This is according to Leo. But according to Lin, the practical position would be distal to the anatomic ridge, and the preferred site would be buccal to the mesiobuccal root of upper 7. So here you can see this diagram where the infrazygomatic crest is being shown, and Lin's IZC7 buccal to the mesiobuccal root of the maxillary second molar, and use IZC6, which is buccal to the mesiobuccal root of the maxillary first molar. So when we look at the IZC7, and if you look at a 12 millimeter length implant, what is it that needs to get into the bone in the attached gingiva and the screw part? So if you have a 12 millimeter length implant, 7.5 millimeter should be in the non-cortical, that is the cancellous bone, 1.5 millimeter should be in the cortical bone, and 1.5 millimeter should be in the attached gingiva, and the 1.5 millimeter would be the screw part. Now if it happens to be 8 millimeters, it is just sufficient that 3.5 millimeter is in the non-cortical part of the bone, namely the cancellous part, but 1.5 millimeter needs to be in the cortical bone, and 1.5 millimeter needs to be in the attached gingiva, and 1.5 millimeter needs to be the screw part. And what should be the angulation? It's approximately 55 to 70 degrees. Now if you look at these pictures here, you can see 7 distobuccal root, 7 mesiobuccal root, and down if you see the green portion, that is the place where there is enough cortical bone for you to place your IZC safely. But if you look at the 6 distobuccal area and the 6 mesiobuccal area, you see that the IZC6 has got a little less bone for you to place your IZC screws. And if you look at these CT scans and these little pictures down here, you can see where the green is, you have more bone, where the red is, you have less bone. In other words, if you're going to do it buccally to the maxillary second molar, you have more bone rather than you having bone buccally to the maxillary first molar. So this shows how an IZC screw can bring about effective retraction of the anterior teeth bypassing the roots, because these screws are placed extra-alveolarly. Well, for the novice, you can take a double film method, which is a 2D radiographic guide for screw placement in patients requiring IZC anchorage. You can also use a pin head soft tissue penetration method. Means to say, if you have these dot pin heads, you just cut the head of the pin and you take a canker sore patch, place the base of it onto the canker sore patch. For example, wherever you want to place. Now this is not necessarily for IZC anyway, even for your microimplant, if you want to place it and you want to see where you're going to put your microimplant or your IZC, you can take an X-ray with the pin head, and then you would know exactly, because you know the pin is going to be a little bit radio opaque, and you know exactly where you can place your microimplant. So it's just an aid for the novice or for the ones who are just starting afresh. People with a lot of experience can place it with a good knowledge of the anatomical portions of the IZC as also the MPS. So certain people, instead of using the canker sore patch, they used to use the comfort brace. Technique is almost the same. So what are the precautions to be taken? A buccal frenum on or near the site can induce laceration, of course, inflammation and screw failure. Fortunately, there is usually no buccal frenum at the IZC6 site. The 5 millimeter width of attached gingiva is adequate for most IZC6 tats. So avoid placing tats between the roots of teeth where the sinus floor is low, because these areas usually have low density bone and a thin cortical plate. So Chang et al. Said IZC screw failure rate is just about less than 7% compared to what Europe thought it is about 20%. So the conclusion was the improved performance of the Chang et al. Method may relate to the favorable soft tissue on the more inferior sides like the IZC 6 and 7 compared to the more superior crestal positions of the TADs used by Europe and Melson. So the different views of two different authors. So what can these IZCs be used for? En masse distalization of the maxillary dentition, for intrusion, for correction of the cant of the maxillary occlusal plane, as also for the correction of the maxillary midline deviation. Now we shall come to the mandibular buccal shelf screws. These are also extra-alveolar screws or extra-radicular screws which are placed in the mandibular buccal shelf. So now you would like to know what I mean by a mandibular buccal shelf area. Mandibular buccal shelf is located bilaterally in the posterior part of the mandibular body, buccal to the roots of the first and second molars and anterior to the oblique line of the mandibular ramus. Why so here? You are going to bypass the roots of all the mandibular molars. There is good buccal bone thickness here, good bone depth and good cortical bone depth. So the insertion site with the optimal anatomic characteristics is the buccal bone corresponding to the distal root of second molar with screw insertion 4 mm buccal to the cemento enamel junction. This was according to Ricardo de Lucera et al., which was published in the Angle Orthodontist in the year 2017. This is a good cue to be taken as to where to place the MBS screw. So you can see the external oblique line, you can see the mandibular molars, and then you can see the red colored portion. That's the area where you can place the MBS, but more so buccal to the distal root of the mandibular second molar. MBS for safe mini screw insertion was considered to be 5 mm of buccal bone thickness. So in this area you need to have 5 mm. Why so? Because 1.7 mm is the safe root distance so that you do not injure the roots of the mandibular first and the second molars. Your screw could be of a diameter of about 1.6, sometimes even 2 mm. You also need to have 1.7 mm of cortical buccal bone. So when the mesial and the distal second molar root scans were taken, it was observed, a very important point here. The mesial root of the mandibular second molar at the 4 and 6 mm showed average bone depths of 18.51 mm and 14.14 mm respectively. But you see what I have highlighted? The distal root of the mandibular second molar at 4 and 6 mm showed average bone depths of 19.91 mm and 16.5 mm respectively. Thus, I reiterate the fact that the distal root of the mandibular second molar is an ideal position for you to place the mandibular buccal shelf screw, because all these sides, let it be mesial or the root, they do show cortical bone depth thickness greater than 2 mm, but better position would be the distal root of the mandibular second molar. Yes, Gandhi et al. In the American Journal of Orthodontics and Dentofacial Orthopedics in the year 2021 had said hypodivergent patients, that is patients with a low mandibular plane angle, have more width and less height of mandibular buccal shelf than hyperdivergent patients. So what do you mean by hyper? They are ones who have a long face or a high mandibular plane angle. So a 2 into 12 mm stainless steel bone screw can be ideally used in the mandibular buccal shelf. So we need to know that the IZC screws and the MBS screws are made out of stainless steel and not titanium. because titanium is more softer and it can fracture. So we use stainless steel screws here. So MBS mini screws were highly successful, 93%, that's quite a good number. And there was no significant difference between placing it in movable mucosa or attached gingiva. So many a time we say we require to place them in attached gingiva. But as we go posteriorly, we are going to encounter more movable tissue. So the failures were more common on the patient's left side and in younger adolescent patients. Why left side and not the right side? The significant difference in the primary failures on the left side was 9.29% versus the right side was just about 5.12%. Once again we ask the question, why? Because of the technical sensitivity of the procedure, because of uncontrolled biological factors such as chewing and brushing habits. At times we tend to brush more so on the left side for the right-handers. We chew more so on one side, that's the left side. And most important, it is difficult for a right-handed clinician to ideally position buccal shelf mini screws on the opposite side. So this could be also another factor why it fails on the left side. And then if you do it in a mature skeleton, means to say in children or in adolescents who have a mature skeleton, it is good. But the ones who are in the growth period and around 13, 14, the quality of the cortical bone in this area seems to be compromised. So the screws could fail here. So that's the reason we need to stress on the fact that mature skeleton is advantageous for MBS screws. So they have found that enhanced regional axillary phenomena occurs when a bone is wounded with a mini screw. Any type of a surgical insult to the bone gives you the wrap phenomena. So this exaggerated hyperinflammatory response may be genetic, such as homozygosity for allele 2 of interleukins 1 beta, which could predispose a patient to periodontitis 2. So this is the area of the MBS, and here you see the attached gingiva there and the MM, which means the movable mucosa. So where can these MBS screws be used? Of course, we know the region where they can be used, but for what purpose can they be used? For en masse distalization of the mandibular dentition, a thing which was a little bit unheard of before the advent of these extraalveolar screws. Intrusion of teeth, correction of the mandibular midline deviation, along with the help of the other screws which could be placed anteriorly too. So dear viewers, thank you all for the patient listening. In part 3, we actually have covered the sites of microimplant placement in the mandible, as also we have touched upon the extraalveolar screws. Now regarding a little information about the skeletal anchorage system and the biomechanical principles which govern the microimplants, etc., we shall deal with in part 4. Thank you all once again.